participate in today's learning session. I have received compensation as an author from the publisher, but do not receive ongoing royalties for or percentage of book sales. We did receive copyright permission to use the cases in this presentation. And Dr. Awan has no disclosures for this presentation. So let's get to the point here, and we're going to take these cases section by section, break them down by history and the immunohematology testing. I'll start off by reading the history. Dr. Awan here will then, go over the relevant clinical history as well as the immunohematology findings. We do want to make this as interactive as possible, so if you do have any questions, just type them in and we'll be happy to stop and address any questions that you have now or certainly at the end of the presentation. So let's get to case number 1, clinical history. So this is a 52-year-old man with a history of hypertension, type 2 diabetes mellitus, and 3-vessel coronary artery disease who was admitted to the hospital for coronary artery bypass graft surgery. An EDTA anticoagulant sample is submitted to the blood bank for type and screen along with an order for 4 units of red cells. No transfusion history. No transfusion history is given. And for those, just to make them aware, an EDTA sample is typically a purple top or lavender top tube, or sometimes you'll see it as a pink top tube, so that you know what types of tubes to collect your type and screen samples in. So Tahid, what is the relevant history here?
So over here, I guess the relevant history would be patient having CABG surgery and no transfusion history. Right.
So the patient is having CABG surgery, which is a fairly big surgery, obviously, and may be at risk for transfusion. Oftentimes, unfortunately, we do not get a transfusion history. So what is the patient's ABO and RH type?
The patient's O positive.
All right, so the way we figure this out is that here you can see that when we do blood typing, we do it on front typing and back typing. So in the front type, we're looking for antigens that are on the patient's red cells. And here you can see that there's no reactivity with the reagent antiserum, so the patient does not have A antigen, does not have B antigen. And in the back type, when we use the patient's plasma, we look for the corresponding antibodies. So here, the patient's plasma reacted with reagent A1 cells, reacted strongly with B cells. So this corresponds with an O patient, and we do the RH or the D phenotype, and we see that the patient is 3+ positive. So this corresponds to an O positive patient. Now we go on and we do the antibody screen, which is also known as an indirect antiglobulin test. So, Tahid, what were your findings on the antibody screen?
So on the antibody screen, we see reactivity on screening cell 2 at 37 degrees Celsius and for A at G.
Right. So what we're seeing here is that the screening cell 1 is no reaction. Screening cell 2, on the other hand, is showing fairly strong reactivity at 37 degrees and also at the AHG, the anti-human globulin, Coombs phase, basically. And what this is telling us, what is the significance of this phase?
So this is telling us that there could be a warm alloantibody because one of the screening cells is negative and one is positive.
Right. So this, you can't really tell much off of when you're doing the antibody screen, simply because you're only getting a 2-cell sample. But you can tell a little bit based on the pattern, and that one of the screening cells is negative, one is positive, so it sort of lends itself more toward an alloantibody, a warm IgG alloantibody reactivity rather than autoantibody. So what's the next step in the workup?
So we would do a panel.
Right. So the next step is we're doing an antibody panel here. And the panel is basically also using the indirect antiglobulin technique. And instead of doing only 2 cells, you can see now that we have 11 cells. So what are we seeing in this panel?
We're seeing reactivity on cell 3 and 6 for both 37 and AIG.
Right. So two of the cells are reacting again with the same reactivity pattern that we saw in screening cell 2, again suggesting a warm IgG reacting alloantibody. What else did you find?
So when we look at the autocontrol, that is negative.
Right. So when we look at the autocontrol, what we're doing here is we're taking the patient's plasma and we're reacting it with the patient's cells. And what this can tell us is if the patient has a possible autoantibody, or if it's a recently transfused patient. By recently transfused, we mean the patient was transfused with donor red cells within the prior 3-month period. It might tell us that the patients might having a delayed hemolytic reaction, for example. But here we see that the autocontrol is negative. So this goes along with a clinically significant warm IgG alloantibody pattern. So how do we identify what is this alloantibody? What is the specificity of this antibody?
Right. So we by rule of exclusion, we can rule out certain antibodies, and then once we do that, we can single out which one we think is reacting and which one the patient has.
Right. So the rules of exclusion mean that we use the negative reacting cells, which are all the ones that are boxed here, and we go across and we actually cross off any cells that have the antigen present. So in other words, because the patient's plasma did not react with cell number 1, we can see that Lutheran B antigen is present on this cell. Therefore, whatever antibody is present in cells number 3 and 6 is not due to an alloantibody to the Lutheran B antigen, so we could cross it off, right? And however, we do have to pay attention to dosage effect. And dosage effect talks about the fact that you can have weak alloantibodies that might not react with single expression of the antigen. So for example, here, if we look at the big S and little s antigens in the MMS blood group system, we can see that even though these are negative reacting cells on cell number 1, we cannot exclude, and cell number 2 as well for that matter, we cannot exclude antibodies to big S and little s because we have double dose. These are heterozygous cells, and you only have single expression of big S and little s antigen. You would need to exclude on what we call homozygous expression, as in here cell number 8, which is showing homozygous expression to big S, but negative reacting. So you could rule it out based on that cell there. While in cell number 9, you have correspondingly little s homozygous expression because there's no big S, and you can exclude little s based on that cell. So if we do all of our cross-offs, right, what do we identify?
So we identified a anti-big E.
Right. So we can see here that we are able to cross off most of the antibodies to most of these antigens. A couple that we cannot because they don't actually have presence on the panel, the Lutheran A and the JSA. But whatever reactivity is here is clearly not due to these antibodies to these antigens. However, we can clearly see that the big E antigen, the antibody's reactivity corresponds with the big E antigen in the Rh blood group system. So we identified here an anti-big E. So getting to our questions, what is the patient's ABO-Rh blood type?
O positive.
Correct. What antibodies did you identify?
Anti-big E.
Correct. Are the antibodies clinically significant? Why or why not?
Yes, anti-big E is clinically significant as it's an IgG, and it is capable of causing delayed hemolytic transfusion reactions as well as hemolytic disease of the fetus.
A newborn, correct. So in general, antibodies to Rh blood group antigens are clinically significant, meaning that they are IgG warm reacting antibodies that can cause delayed hemolytic reactions or cross the placenta in a pregnant woman and cause hemolytic disease of the fetus and newborn. Next question, how many RBC units would you need to screen in order to find 4 compatible, i.e. negative for the corresponding antigen, in this case, big E negative units, as requested?
So for this, we would need to refer to the table of RBC antigen frequencies. And when we look at that, we see that 29% approximately of the Caucasian population carry the Rhe antigen, and 71% do not carry it. So we would divide 4 by 0.71, and that would give us 5.6, and we can round that to 6. So essentially, we would need 6 RB units to be screened in order to find 4 Rh big E antigen negative compatible RBC units.
Correct. So the reason that we're using the antigen negative frequency is because when we cross match, we want to avoid the big E antigen in order to find compatible units. So therefore, if approximately 29% or 30% the units are positive, therefore 70% of the population, the Caucasian population, would be negative. And therefore, if we're looking for 4 units, we divide by 0.7 and come up with approximately 6 units. The reason that we use the Caucasian population is because the majority of blood donors in the United States tend to be Caucasian. So we just use their approximation. But of course, that would change based on your donor population in various regions. All right, and again, for the audience, if you do have any questions, feel free to chime in, and we're happy to stop and address any questions at any time. Case number 2. So in case number 2, we have a 25-year-old woman, gravida 2, para 1, at 37 weeks of pregnancy, who has not had any complications throughout the pregnancy, presents for routine prenatal clinic visit. A type and screen sample is submitted to the blood bank. So Tahid, what is the relevant clinical history in this case scenario?
So there are a couple of things in the history. One, that the patient is 37 weeks pregnant and is here for a routine prenatal clinic visit.
Right. Okay. So she's nearly a term pregnancy. And what is her ABO Rh type?
The patient is A negative.
Correct. So the way we pick that out is, again, on the front type, the patient's using the reagent anti-sera, the patient's red cell reacted strongly with anti-A, 4+, negative with the anti-B. And in the back type, you can see that there's a corresponding antibodies to the B cells in the patient's plasma. So this corresponds with an A type, and then you can see the D reagent did not react with the patient's red cells, so this patient is an A negative, right?
Yes.
So what about the antibody screen?
The antibody screen shows reactivity on both screening cells at 37 and at the A and G.
Correct. So we're seeing weak, 1+ to 2+ reactions in both cells, and this could correspond with either an allo or an autoantibody. We can't really tell based on these 2 screening cells. So what is the next step in the workup of this patient?
So we would do a panel.
Correct. So here we have a 2 panel, and what are we seeing?
So we're seeing reactivity almost half the cell lines, or 4 or 5 cell lines, at 37 and at A and G, and the autocontrol is negative. Right.
So we're seeing about half the cells are reacting with the same strength as what we're seeing in screening cells, 1 to 2+ at 37 and AHG. So this corresponds with what looks to be like a warm reacting antibody, except for cell 11, which has weak reactivity as HG. And the autocontrol is negative, which tells us what?
That this could be an allo.
So this is corresponding to a warm reacting alloantibody, right? So what were you able to identify based on the negative reacting cells?
So based on the negative reacting cells, we could locate anti-D. We can't completely rule out certain antigens.
Yeah, you can't rule out the CW and the V antigen in particular. But again, whatever reactivity we are seeing, is probably not, it's certainly not all of the reactivity would be due to either of those. So in reality, we might have to do more workup if this were a real live patient in order to rule those two specificities out. But in the meantime, what were you able to identify in this case?
We could identify an anti-D.
Right. So the reactivity is corresponding with an anti-D, right? So what is the patient's ABO-RH blood type?
A negative.
So the patient, as we explained, was an A negative. What antibodies did you identify?
An alloantibody against RSD antigen.
Right. Can the weaker reaction on cell number 11 seen in the panel be explained?
Yes, that can be explained. Cell number 11 is an R0 R prime red cell. That means that the RSD antigen is on the opposite allele or in the transposition relative to the RHC antigen, which is also known as the Cepelini effect, and that sometimes can cause these weaker reaction strengths.
Right. So what's important to take away here is that many lay people and even clinicians believe that the D antigen, which basically signifies whether you're Rh positive or Rh negative blood type, is black or white. Either you're Rh positive or you're Rh negative. However, in reality, there's a lot of gray zone in between when it comes to the D antigen expression, and we have what we call weak D types and even partial D types. And the reason you can have this is because of either point mutations, for example, that might relate to weaker D expression on your red cell, or you can even have missing subepitopes. The D antigen is a very big protein, transmembrane protein antigen that sits on your red cell. And if you're missing any of these subepitopes, you can actually, what we call phenotype is what we call partial D type. Some of these types are prone to actually becoming immunized, meaning they can make anti-D. And one of these subtypes of a weak D expression is what we call the Cepelini effect, or the big C antigen, which is this antigen here, in trans position, meaning it's inherited from the opposite chromosome to the D antigen. So you have a single copy of D antigen here, compared to the single copy of the big C antigen here on the opposite chromosome. And that can cause weaker expression of the D antigen, and thus antibodies might react weaker with that cell. The R0 little r prime, for those who are interested, is a certain type of nomenclature that we use, known as the Wiener nomenclature, after Alexander Wiener, who promoted the single gene, single antigen theory about Rh inheritance, whereas the Fisher-Race theory, which is this terminology here, promoted the three gene product theory. Neither one turned out to be correct, as Tippett actually later figured out that there was only two genes, one for the D and one for the CE. So you have two genes and two gene products. But that's really neither here nor there. The point here being that you just have a weaker expression of the D antigen on this cell, and as a result, you're getting weaker reaction. Okay, so next question. What are the possible causes or sources of the antibodies in this patient?
So there are a few possible causes. One possibility could be that the patient was transfused with RHD positive blood products in the past, either in a case of emergency or by mistake. The second possibility is that the patient developed these antibodies as a result of fetal maternal hemorrhage. But the most likely explanation in this case is that passive administration of anti-D was given to this patient.
Correct. So there are two ways you can get anti-D. One, as Tawhid was mentioning, is it could be through exposure, either through mistransfusion of Rh positive blood or emergency transfusion of Rh positive blood to the patient, this Rh negative patient, or possibly due to a significant fetal maternal hemorrhage that wasn't picked up during pregnancy, either this pregnancy, early in this pregnancy, or prior pregnancy, causing active immunization. But more likely, given that this patient, had an uneventful pregnancy at this time and is now near-term pregnancy, it's more likely that the patient was given Rh immune globulin, or what's commonly referred to as RhoGAM, after the Johnson & Johnson brand name. And that's used as prophylaxis to prevent RH immunization, and it's commonly given at 28 weeks of pregnancy, and again, postpartum within 72 hours of delivery of an RH positive baby to an RH negative woman. So RH negative women do receive it at 28 weeks, and that's probably what the case is here. So what additional testing would you do in the blood bank to help you determine the nature or source of the antibodies?
Apart from taking careful history, another thing that we could do is we could look at the titers, the anti-D antibodies. That could help us distinguish whether it's via active immunization or passive.
Correct. So if we do a titration, meaning we're looking at the level of the antibodies, how much antibody is present in the patient's plasma, we can determine whether low levels are present or high levels. And basically, when you're giving RH immune globulin or RhoGAM, the titer would be expected to be low because you're only giving a very small amount of the antibodies. And over time of the pregnancy, the amount of antibodies would be expected to drop. So you wouldn't be expected to have a titer of greater than 4 if it's RH immune globulin. And typically, we only see the titer of a level of 1. Certainly, if you're seeing higher titers than that, then you have to suspect that the patient really is actively immunized, and that could put her into a high-risk obstetrical category where she really needs close monitoring, and the baby really needs to be closely monitored during delivery of this baby, and certainly in future pregnancies should she decide to have future children. All right, case number 3. So this is a good case that really highlights transfusion safety and the problems that can arise. So the history here is it's a 41-year-old woman with Crohn's disease who presents for outpatient transfusion. The patient has a history of symptomatic chronic anemia as per the patient's gastroenterologist and has received several blood transfusions at another hospital in the past, though none in the past 2 years. So these are old transfusions. An EDTA anticoagulant sample is submitted to the blood bank, which is properly labeled with the patient's last name, first name, and medical record number and date of birth. So it's Smith, Julie, medical record number 1001234, and date of birth is 3/20/1978, since it's 41 years ago from the current date. For type and screen, along with a request for cross-match of 2 red blood cell units. There are no prior tests, i.e. type and screen results in your blood bank information system. In fact, this is the first admission to your hospital for this patient, so it's a new patient. So what is the relevant history here, Tawhid?
So there are a few things that are pertinent in this history. One, that the patient has symptomatic chronic anemia and has not had any transfusions in the last 2 years, and has 3 patient identifiers, as you mentioned, and this is the first admission to the hospital facility.
Correct. So, so we have a new patient here who's coming in for outpatient transfusion. And what is the ABO-RH antibody screen?
So the patient is A positive, and the antibody screen is negative on both cells.
Correct. So as we described before, the patient, for front typing and back typing for ABO, the patient cells reacted strongly with anti-A, negative with anti-B. The patient has anti-B antibodies as expected in a group A patient, and the D reactivity was 3+ on the patient cells. So this corresponds to an A positive patient, and the antibody screen is negative here. So there's no clinically significant alloantibodies. So what is the patient's ABO-RH blood type? As we described, this is an A positive patient. Now, what method would you use to perform compatibility testing, essentially cross-matching for this patient based on the sample and test results of the first admission? And what would be the ABO-RH type of the RBCs that you would cross-match? What risk is involved?
So we have 3 options of performing the compatibility testing here in the US. One is the immediate spin cross-match. The second is using electronic computer cross-match. And then the third one is the anti-human globulin, or also known as the full cross-match.
Right. So, So the FDA allows these three types of cross matches, and what's the difference between these three cross matches? What is the immediate spin testing for?
So that is testing for ABO compatibility, and is a quicker method of finding that. Whereas the full cross match, you get to locate and isolate other antibodies or antigens that the patient might have.
Correct. And what about the computer cross match or electronic cross match?
So the computer cross match, basically you have to have a validated system in order to perform that, and you should and have to have information already in the system that you can correlate.
Okay. So which method would you use at this point in time for this patient?
So for this patient, we would use the immediate spin.
Right. So in this case, we would use an immediate spin, which, as Terry pointed out, only matches for ABO compatibility. So what is the risk involved with that?
So the risk is that you could have a wrong blood in tube case, where the sample is properly labeled with the correct patient information, but is collected from the wrong patient.
Right. So assuming that you're giving this patient blood that matches the patient's ABO type, in other words, A positive blood, one of the biggest risks is what we call wrong blood in tube, which means that the sample was labeled properly with the intended recipient, but the sample was actually collected from the wrong patient. And this is, unfortunately, happens all too common when, phlebotomists or nurses or residents or who's ever collecting the blood collects the sample, labels the sample at the nursing station or remote from the patient's bedside, then goes to what they believe is the correct patient, collect the blood, and then send it to the blood bank for cross-matching. And so it's labeled properly, but it has the wrong patient's blood in the tube. And so that's why it's termed wrong blood in tube. Now, if the blood bank doesn't have prior history on this patient, so it cannot check the patient's prior history, and it does the type in screening on the patient, well, it could come up that the patient is an A positive when in fact it's the wrong patient and the right patient is really an O positive. And if they do cross-match A positive blood, that of course could lead to an ABO hemolytic reaction, which can be have severe consequences on the patient and even be fatal. So we have additional history here. The patient receives the 2 units of RBCs in the outpatient transfusion suite without incident and is discharged home. The patient returns to the hospital for outpatient transfusion 8 months later, which is now the second admission, and another EDTA sample is received in the blood bank labeled Williams, Julie, medical record 1001234, date of birth 3/20/1978. There was a request for 1 unit of RBCs. Test results are as below. So what is the relevant history here? That we have the relevant additional history.
So one, that it's 8 months later, so it's more than 3 months.
Right.
And then secondly, we see even though the MRN and the date of birth of the patient is the same, the last name has changed.
Correct. So the date of birth and the medical record number match, but the last name has changed, calling into question this patient's identity. And what about the antibody screen, ABO-RH and antibody screen in this patient?
So that's similar to what we had before. She's an A positive patient with antibody screen not reacting on screening cell 1 and 2.
Correct. So as we've been previously describing, again, the anti-A reacts strongly with the patient's red cells, negative with the B. In the plasma, we see antibodies to B cells and reactivity with the patient's red cell with the D antigen. So this, again, matches what we had seen previously. And this is an A positive patient. So the ABO type matches up with the historical type, even though the patient's name has changed. And the antibody screen, again, is negative. So what method would you use to perform compatibility testing for this patient based on the sample and test results of the second admission? And what would be the ABO-RH type of the RBCs that you would cross-match? And what risk is involved?
So in this case, because it's a second admission, we could use the electronic computer method to perform compatibility testing, provided that it's a validated information system.
Right. So that's correct. Again, the electronic or computer cross-match is a method that's an abbreviated cross-match. It's used for convenience and turnaround time, but it only measures for ABO compatibility. And the way it works is that you have to have at least 2 type determinations on the patient. Normally, that's taken to mean you should have at least 2 samples, although technically you're allowed to use the same sample, but that's, most places won't do that, because if it's a wrong blood and tube situation, that'll, you'll still pick up the same error. So most places require at least 2 samples. It can be a current sample and a historical type, or even on two current samples that were drawn separately. You also do have to have a computer system that is validated for the computer cross-match and prevents ABO mistype blood from being released. The other issues, even with the immediate spin and with the electronic cross-match, is that the patient can have no clinically significant alloantibodies on the current sample or by history. So it should have a negative antibody screen and no history of clinically significant alloantibodies, as in this case. So you do have a second sample now, assuming that this is the same patient. The antibody screen is negative, and so then you can go ahead and do the electronic cross-match. So what is the risk involved here?
So the risk would be, because of the change in the last name, misidentification could be one risk. So a second sample would be preferred.
Right. So the risk here is because the patient's name has changed. If there is any issues that it turns out to be a different patient than Smith Julie, if Williams Julie really turns out to be a different patient, that could and you do release a positive blood, that could lead to a hemolytic reaction. So confirming the patient's identity is very important. Potentially even getting another sample just to confirm that the patient really is an A positive could be another way to go about that. So we have further history here. Upon inquiry by the blood bank supervisor regarding the patient's last name, the nurse in the outpatient transfusion department relates that the patient got married in the interim after the initial visit. The nurse emphatically verifies that it is indeed the same patient. The patient is transfused a unit of RBCs without incident and is discharged home. 1 year later, the patient is admitted to the hospital. Now it's the 3rd admission for surgery, and a preoperative EDTA sample is received in the blood bank for type and screen. The results are as below. So what is the relevant history here?
So now, as we know that the patient did get married, it is the same patient. The patient was transfused a unit without any incident, and this is her 3rd admission for surgery.
Correct. So we verified now that in fact it was the same patient. She did get the blood, presumably a positive blood that was without incident, and she's admitted. Now comes back a year later. Now this is the 3rd admission to the hospital. And what about the ABO type?
So
RH.
This is, again, similar A positive, but this time we see that the antibody screen is reacting on screen cell 2 at 37 and for AHG.
Correct. So we've again verified that the patient is an A positive patient. That matches. But now the antibody screen has become positive. And we can see that this is a warm reacting IgG antibody that has the pattern, looks like an clinically significant alloantibody based on the pattern, right? So what do we need to do next?
So we will go for a 2-panel.
Right. So what is the 2-panel showing us?
So this is showing reactivity on 2 cells at 37 and AHG, similar to what we saw before, with the autocontrol being negative.
Right. So we have 2 cells that are positive, other cells that are negative, and then what are we able to rule out?
So we could rule out almost all the other antigens, and single out N-type big E.
So again, like as in the first case, we're identifying an allo N-type big E here. which again, as we mentioned, is a clinically significant warm-reacting antibody to E antigen, which is in the Rh blood group system. So it can cause delayed hemolytic reactions, and in females of childbearing age, hemolytic disease of the fetus, and newborn. So what method would you use to perform compatibility testing for this patient based on the sample and test results of the third admission?
So because we located an anti-big E and it was a positive antibody screen, continuing with an AHD full cross match would be preferred in this case.
Right. So, well, not only preferred, you would be required to perform the AHG full cross match because now the patient has developed a clinically significant alloantibody. So the upside of the AHG cross match is that it not only detects incompatibility for ABO compatibility, it also detects compatibility for the minor antigens, as in this case, the RH and the E antigen. The disadvantage, of course, is that unlike an immediate spin or electronic cross match, which only take minutes to perform, they're very quick. The AHG cross match or full cross match can take up to 45 minutes to perform because you have additional incubation, washing, and Coombs addition of the Coombs reagent to perform. So it's it slows down the turnaround time, but it is required once the patient has developed clinically significant alloantibodies. Even if you don't detect those clinically significant alloantibodies, but the patient has a history of them, you are required to do the full cross match. Okay, again, for any audience out there, if you want to chime in with any question, we're happy to entertain any questions at any time. Case number 4. So this is a 35-year-old woman with a history of prior cesarean section, now presents at 39 weeks of gestation for repeat C-section. A sample is submitted to the blood bank for type and screen along with an order for 2 units of red blood cells. The patient has no history of prior transfusion. So what is the relevant clinical history here?
So the patient has a history of prior C-section, is here at 39 weeks for a repeat C-section, and that the patient has no history of any prior transfusions.
Correct. So she's basically at term pregnancy. The point about the repeat C-section is she may have a little bit scarring, which can engender a little bit more bleeding and risk for transfusion. So they are asking for 2 units of red cells. And what about the ABO type and RH?
So the patient is A positive and is showing weak reactivity on screen cell 1 for AHG.
Right. So we're seeing, again, as we previously mentioned, patient's red cells react strongly with A. No reactivity with the anti-B reagent. The back type shows antibodies to B, which corresponds with an A type, and is reacting with the anti-D reagent anti-series, so it's an A positive. Antibody screen is only weakly positive AHG, and we need to do the panel to determine what that antibody might be. So here, what is one difference you see on this panel now in terms of the phases that we're reacting at?
So we see an addition of the immediate spin phase in the test results, and that's showing positive reactivity for 4 cells. That's corresponding to the weak reactivity on AHG as well.
Right. So here we see that not only are we doing warm reactions at 37 and AHG phase, but we're also using immediate spin, which is typically taken to mean cold reactivity, and we're seeing some fairly strong 2+ cold reactivity. Can you tell us a little bit about what this CC means, since we're seeing it in all the panels and on the screening cells?
So these are known as the check cells, and they're basically used as a control for the negative AHG reactions.
Correct. So we call them either check cells or Coombs control cells. And they're really, as you mentioned, negative controls for negative reactions with the AHG. So whenever we see negative reactions, we add in the check cells. The check cells are really IgG-coded reagent red cells, which should convert a negative reaction with AHG to positive. And the reason we added is to make sure that our Coombs reagent was added or is properly working. So it should be positive. When we do get positive reactions with AHG, as in cell number 3 here, we don't use the check cells because we already have positive reactivity. All right, so moving on, what were you able to discern from the see in this panel?
So we couldn't rule out a few antigens like the KPA or the V and the big E, but those are most likely to react at warmer temperatures. So we could isolate the Lewis A antigen.
Right.
That's the most possible one.
Right. So we're seeing the 4 reactivities at immediate spin at 2+. The autocontrol down here is negative, so that would signify an alloantibody. And then using the negative reacting cells, we can rule out most of the specificities. Really, the E we can't because we only, as we talked about at the beginning, in the first case, we were looking at homozygous versus heterozygous expression. And so here, we can't rule out the big E on cell number 3 because it's a positive reaction. And we can't rule it out on cell number 6 because it's a heterozygous expression with the little e. So we can't quite rule out the big E, but but we are seeing cold reactivity, and these weak reactions are representing what we call carryover or leftover reactions from the immediate spin. So these are not really reacting at Coombs phase; they're just leftover cold reactivity. And then based on that, we can see that they correspond to the Lewis A specificity. So we're identifying an anti-Lewis A. So we mentioned that the patient is an A positive, and you identified an anti-Lewis A. Is that clinically significant?
So usually they're not clinically significant because they're cold reacting IgM antibodies, but rare occasions they can react, but usually they're not clinically significant.
Right. So in most instances, Lewis antibodies, either anti-Lewis A and or anti-Lewis B, are cold reactive. And there are other specificities where we typically see antibodies that are cold reacting, such as anti-M as in Mary, anti-N, anti-P1. These are relatively common cold alloantibodies that can develop, particularly the M and the P1, as well as Lewis antibodies. So are the antibodies clinically significant?
So these antibodies are not clinically significant, and the baby is not at risk for hemolytic disease of the fetus or newborn. And these are basically, they normally attach after birth.
Right. So the point is that antibodies to Lewis A and or Lewis B are typically IgM cold reacting. So they don't react at 37 degrees, so they don't cause delayed hemolysis. And because they're IgM, they don't cross the placenta and wouldn't harm the baby, wouldn't cause HDFN. Plus the fact that when do Lewis antibodies develop in development? Well, Lewis antigen is typically not an intrinsic RBC antigen. It's actually antigen that is in the plasma and secondarily attaches to red cells, but that attachment doesn't occur until sometime after birth. So Lewis antibodies really are not, never really cause hemolytic disease of the fetus and newborn. So the baby here is not at risk. All right, our final case for this presentation is case number 5. So this is a 58-year-old man who presents to the hospital for knee replacement surgery. The patient has a history of transfusion at another hospital some years ago after gastrointestinal bleeding. A type and screen sample is submitted to the blood bank. So what is our relevant history here?
So 2 pertinent findings would be that patients here for knee replacement surgery, and the patient has a history of transfusion some years ago.
Right, so he has a history of old transfusion. Again, we differentiate recent from old transfusion at the 3-month mark, if it's because that's the survival of transfused red cells. So if it's a transfusion within the prior 3 months, some donor cells may actually be still circulating in the patient, and that can affect some of our testing, like phenotyping, for example, versus older transfusion. However, it's still important to elicit a history of transfusion, as it could signify that the patient may have made clinically significant alloantibodies. So what about our ABO-RH typing?
So the patient's O positive.
Correct. So again, no reactivity with anti-A, no reactivity with anti-B. Both A and B cells in back type are reacting, so patient has anti-A and anti-B antibodies, as you would expect in an O patient, and is reacting with the anti-D, so the patient is Rh positive. And our screening cells?
So both screening cells are showing positivity on the gel method.
Right. So now we're actually using a different methodology here. Gel is a little bit different than tube testing. In tube testing, we add our reagent cells, our cells rather, and or reagent cells in patient plasma to a tube, and we swirl and we look for agglutination. Whereas in gel, we actually have polyacrylamide porous gel, which is usually typically lined with anti-IgG, and we add our reagents, our red cells, and in patient plasma at the top, the reactivity chamber. We then incubate and drive down the reagents, reactants through the gel through centrifugation. And if they get caught up in the gel, we have a positive reaction. The advantage of gel is that it's a little bit more sensitive than tube testing, and it can actually be automated. We have automated platforms. So a lot of blood banks now have switched over to to gel testing. As opposed, but we still use tube testing as sort of a backup method, or if our gel testing might not be picking up something, or we have concerns, we can use tube as a backup method or confirmatory method. So we move on to the gel panel now. So what is our gel panel showing us?
So when we look at the panel, we are seeing variable reactivity throughout cell 1 to 11. The autocontrol is negative.
Right. So it's important to know, just go back here, that we're seeing reactions at 2+ in many of the cells. 2 of them are reacting only weakly positive, and as you mentioned, the autocontrol is negative, signifying what?
That this could be a alloantibody, and we don't have a autoantibody.
Right. So we don't have autoantibody, and we possibly have more than one antibody present because of the difference in the reactivity at 2+ and weakly positive. Alternatively, sometimes you see differences in reactivity, as we've been talking about, due to a dosage effect. In other words, the heterozygous cells might be reacting weaker with the antibody than homozygous. So we need further testing to differentiate that. Additionally, we're seeing some additional results here. And what is the additional results that we're seeing on this panel?
So if we follow the KID antigens, we see a JKB as a 2+ phenotype, and this shows that this patient probably has a JKA negative. Right.
So here we're doing additional phenotyping on the patient cell. Just like we do ABO and RH or D typing, we can also type for other specificities. So here we're typing the patient's cell for JKA and JKB, and we're seeing that the patient is homozygous JKB positive and is lacking the JKA antigen. So what does that clinically signify? It signifies that the patient might be able to make a JKA alloantibody, but would not be at risk of making JKB, because you don't make alloantibodies to antigen that you have present on your red cells. So it effectively excludes the possibility of making an anti-JKB, but leaves in the fact that the patient might have an anti-JKA, which are in the clinically significant antibodies in the KID blood group system. So we need to do further testing. Well, actually, here we can do some rule outs rather on the negative cells. And what could you rule out?
So we could rule out a few of the antigens. We could rule out N, Lewis A, JKB, as you mentioned, Duffy B, JSB, JSA, KPB, and then because the patients are as positive, we can rule out D as well.
Right. Because we only have 2 cells that are negative, we can rule out only a few of the specificities. And as Tawhid mentions, we can rule out the Lutheran B, the P1, the little s, big S, the N, Lewis A, JKB, Duffy B, JSB, KPB, the little K, the F, and the little E. But there's a lot of ones that we cannot rule out, including the big C, big E, the little c, the CW, the V, the big K, which is the Kel, commonly referred to as the Kel, KPA, the Duffy A, Lewis B, and M. Some of them we're not as worried about because they're typically cold reacting, as we mentioned before, like Lewis B and antibodies to M are often, M are typically IgM cold reacting, but others we would be worried about. So, what were you able to identify anything?
So we could identify a JKA alloantibody.
Right. So if we look at these stronger reaction cells, the 2+, it corresponds to the JKA. And if you remember, the patient was JKA negative. So we do suspect that the patient has an anti-JKA, which is a clinically significant alloantibody that can cause acute and or delayed hemolytic reactions. It can cause acute because KIT antibodies are very good at activating complement and even causing not only extravascular hemolysis, but in some cases intravascular hemolysis. Well, we still have these weak reactions here, right? So what could we do with those?
So we could do a 2-panel next and try to elicit a reason for those weak reactions.
Right. So again, in this 2-panel, what do you know that's different here in the phases of testing?
So we've added 4 degrees Celsius testing, which is showing pan-agglutination.
Right. So pan-agglutination means that all of the cells are reacting, and they're very strongly reacting here. What else do you notice?
So we also see that it's positive in the autocontrol.
Right. So how do we categorize this, this antibody?
So this would be a cold autoantibody.
Right. So this is a cold autoantibody. We're still seeing 1+ reactions at HG, which could be leftover reactivity from the cold. However, it is corresponding with the KIT antibodies. So we're seeing the KIT warm reactivity behind this cold autoantibody. So here we're doing a selected cell rule-out panel because remember, many cells we couldn't rule out many antigens. And what are we selecting for here?
So we're selecting for the ones that were negative.
Right. So we're selecting for the JKA negative cells because we want to rule out specificities to the other antigens that we could not rule out, including the big C, the big E, the little c, the CW, the Kel, the big K, the Duffy A, Lewis B, and the M. So could we rule those out using this panel, this selected cell panel?
Yes.
Yes, we can, because we have all negative reactions, and we could clearly see that we have cells that are that are positive for these antigens, homozygous M here, Lewis B, homozygous Duffy A here. The big K, you can never really find homozygous because of the little k antigen is like 99% present in population. So, but we use heterozygous cells, so it's negative. CW, and the others as well. So we can rule out everything else, and we've identified an anti-JKA with a cold autoantibody. Are these antibodies clinically significant?
Yes, the anti-JKA antibody is clinically significant. It can cause hemolytic transfusion reactions, hemolytic disease of the fetus and newborn, and it can also cause intravascular hemolysis as they activate complement.
Right. What about the cold auto?
The cold auto antibody is, on the other hand, not clinically significant.
Right. That was reactive at 4 degrees. As IgM is not clinically significant. What is the purpose of the selected cell panel? As we mentioned, that was to rule out additional antigen specificities that we couldn't rule out on the original panels. So how many red blood cell units would you need to screen in order to find 2 compatible negative for JKA units in case the patient needs transfusion?
Right. So similar to the previous case, we would look at the table for RBC antigen frequencies, which would show that JKA antigen is approximately 77% in the Caucasian population, and there's a 23% chance of finding RBC unit that is JKA antigen negative. And as they requested 2 units, we would divide 2 with 0.23. That would give us 8.69. Roughly 9 units would be needed to be screened to find 2 units that are JKA antigen negative.
Correct. All right, so we're at the top of the hour here. We thank everybody for participating. If there's any questions, we're happy again to entertain any questions in the couple of minutes that we have left. Otherwise, today's Pathcast attendance code is 100077. In order to receive AOA CME credit, please log into PCOM's registration site at http://continuing.ed.pcom.edu and sign in with your email and password. Use the email and password you created when you registered for the event. Enter the event attendance code into the text box and complete the evaluation. Once this step is complete, you may print out your certificate of completion. So we thank you again for participating in today's event. Hopefully we found this to be a positive learning experience. Again, we know that blood bank transfusion medicine is not common among clinicians, but it is an important topic for transfusion safety. Thank you.
Excellent. Thank you so much, Dr. Friedman. So I don't see any questions in the Facebook or YouTube chat windows, but the video will remain posted for on-demand viewing on the Facebook and YouTube pages. So if any questions come up, I'll be happy to forward those to you. But so no questions right now. Thanks again for that interactive discussion on immunohematology and transfusion medicine. And thanks again to the folks over at PCOM for the AOA credit.
All right, thank you,
Thank you,
Dr. Madrigal, and everyone else.
All
Thanks.
right.
Have a good day.
Take care. Bye-bye.